I hope you've all enjoyed so far the morning session, and for you that are patients, one of the things, and I think we should go back here, that some of the doctors were talking about publications, the number of publications that have been made about CCSVI, and you know, it's I think it's estimated now that we have like 20,000, 25,000 people in the world that have been treated for CCSVI. And did you notice how many papers? There's hardly any that have really been published. So the doctors, if you are going to go be treated, I would make sure that you're going to be in some kind of a trial, a study, an IRB. David Hubbard is sitting back here. He's got a registry. He's got an IRB. Doctors, you can get on with him. But we need to start tracking the patients, and we need to get publications out there and in front of the medical community. So, Mike, do you want to come on up, and then maybe your voice will get some of the other people in here. So, again, please refer to your program. It has all the bios in it, and I would like to introduce to you Dr. Michael Dake from Stanford University. And I will say this, he was my treating doctor back in 2009.
Thanks very much, Sharon. It's a great pleasure to be here with you this afternoon. See so many of you. It's hard to believe. I mean, we think things move slowly, but actually when we say 2009 to 2012, things have moved rapidly. And here we are in Orlando at actually the second annual meeting of the ISNVD and patient days. And as you know, we have a lot of patient days around the country, and the CCSVI Alliance certainly is instrumental in doing that. I've got 9 minutes, so I have to sort of go fast. These are my disclosures, none of which have any relevance to what we're going to talk about or CCSVI. So how did we get here? Well, no matter what we do in life or where we come from, we tend to sort of organize ourselves in groups. And as you can see here, these happen to be fish in the water. That's a swarm of fish. And we tend to take a lot of, I think, security and confidence when we run around in these groups, and we tend to believe things that we're told, and this reinforces, etc. But every once in a while, something comes along, and a couple little fish, you can see at about 5 o'clock, sort of break away from things. And that causes some cognitive dissonance within the group. And that's kind of where we are with CCSVI in terms of experience of maybe other specialties, other physicians. Obviously, we all agree that healthy skepticism is not only necessary but desirable. And I think many of us still remain sort of agnostic, meaning that we don't really know everything we need to know, and that, again, always makes us a little insecure. But this is how it starts. A couple fish coming out like that, and we can translate from fish to humans, and sometimes as we work in our little ball of things, it's necessary to, I think, sort of break away, and with that, I think, comes some challenges and oftentimes some insecurity, because once you get away from the group, it is a little lonely. But all of us coming together certainly reinforces for us the benefits that can come when we explore things in new and different ways. Well, speaking of new and different ways, back in 1867, it was Charcot who, of course, was the first to describe not only the clinical but the pathological features of MS. And I think now, where we are, and soon after that, and I'm going to put this down so hopefully you can hear this. This is from last year's ECTRIMS.
I'm Kate Milliken, and welcome back to the ECTRIMS Conference and the Daily Minute. The topic of CCSVI burst onto the scene 2 years ago, and it has received a lot of attention. Dr. Robert Fox gives us some insight into some recent findings.
The CCSVI theory actually dates back over 100 years. Very soon after multiple sclerosis was diagnosed, its association with blood vessels was recognized.
Okay. So right after Charcot, it was recognized that blood vessels were indeed had some role in MS. And now we've come wherever we've come to now with CCSVI. Obviously, 150 years later, we're back where we started from. But what have we learned about the diagnosis of CCSVI? We talked earlier in the first session, I was here when we talked about catheter venography and MR venography and certainly Doppler ultrasound. It started with Dr. Zamboni and the criteria that you're very familiar with. We've sort of dropped over the last 3 years, relying on the deep cerebral veins by TCD, not because we don't think that's valuable, but that takes another level of sophistication and technical skill to do that. So really rely on 4 criteria now, and still requiring 2 or more duplex parameters to be positive for CCSVI. And again, this is from Dr. Zamboni, one of his landmark articles that showed, again, no matter what type of MS, relapsing or progressive, there's a very high frequency of these individual criteria compared to the control population. Now, Eric showed this earlier, and I will show it to you again. This here is what I see occasionally, and many of you have seen, a septum coming across, and that, again, is where ultrasound is extremely powerful in looking at valves. MR, even catheter venography, possibly intravascular ultrasound can give us some insight, but clearly we rely very heavily still on external ultrasound to look at valvular function, to look at interluminal abnormalities, things that are associated with valve malfunction, and perhaps even anatomic abnormalities that are congenital with the valves. And what this causes, of course, is turbulence, and that may be reflected back up intracranially that can cause, again, flow disturbances in the brain. In terms of venography, there have been a lot of articles, and I'm sorry I'm not going to have a time to do a comprehensive review of all the literature, so I don't mean to slight any articles, but I just want to highlight some things that we've learned in the last 3 years. And looking at different types of venography, this article by Dr. Siskin showing again and trying to really make sense of all of these abnormalities that are seen on venography, some of which, as you heard earlier, are intrinsic, involving the valve apparatus or the vein itself, some of which are extrinsic and functional, regarding pressure from external to the vein forces. We at Stanford looked at comparing then MR and contrast venography in the cervical venous systems and find there is actually pretty good comparison, certainly in terms of stenotic disease, less so in terms of the collateral pathways. But again, I think each of these illuminates the next step we're going to take in terms of our trying to increase our understanding. What other people have shown, I'm just going to highlight again, decreased cerebral blood flow, volume, mean transit times by MR, increased size of third ventricle and decreased CSF flow by MR, decreased cerebral oxygen saturation, increased iron content. You're going to hear a lot more about all of these individually, but these are all things that really prior to 2009 we just weren't really aware of, we weren't even looking at, and so obviously a lot of the findings we're seeing now were passed off as normal variants or insignificant, etc., because they weren't attached to any identifiable pathology or disease. Now, when we talk about flow, it's very interesting to know that people with MS who have hypoperfusion, the hypoperfusion precedes development of the MS plaque. And this, again, is slightly before 2009, but I think since this article there have been other studies published that again show that even in normal appearing white matter, hypoperfusion precedes development of any disease that's detected by MR imaging of anatomy. And that the disease state, in other words, how far progressed the MS state is associated with lower cerebral blood flow and cerebral blood volume. Again, this is from recently, 2006, showing that the pattern of hemodynamic impairment in multiple sclerosis, this was from NYU, shows that, again, hypoperfusion is clearly seen in normal appearing white matter. So the question, and here you can see between controls, relapsing remitting, and primary progressive, again, demonstrating significantly lower flow when you get into progressive disease. Now, so there's lower flow. What does that mean? There could be lots of reasons for lower flow. It doesn't have to be something to do with the veins. It could be that the actual tissue in the brain is not metabolizing properly, or that it's degenerating and we just have lower vein volume, so possibly the flow is less. And this study, again, relatively recently, indeed shows that what this is indeed ischemia. It's not due to tissue degeneration. And if you look at this, it says the results of this study correlating diffusion tensor imaging and perfusion changes are more consistent with what would be expected in primary ischemia, a vascular pathology or condition, than in secondary hypoperfusion from Wallerian degeneration or degeneration of neurotissue. Now this is important, so we are laying in a mosaic of puzzle pieces here, and we haven't really seen the final product yet, but each one of these pieces does add to our eventual enhanced understanding. And this again from Dr. Zamboni, showing that hypoperfusion correlated with the venous hemodynamic insufficiency severity score. So now we're tying this hypoperfusion, which we said is ischemia, and this ischemia to actually something to do with the veins. And what you see on the left from his article is a 33-year-old with relapsing remitting who had a venous insufficiency severity score, which can roughly translate to the severity of stenoses, of 5, as opposed to the patient in panel B, which is a 38-year-old with CCSVI and relapsing remitting and has a severity score of 12. So again, the higher the number of stenoses, the increase the severity score, the more hypoperfusion. And then again from Dr. Zavadinov, showing that the more extracranial venous stenosis, or the more progressed the CCSVI, the more significantly decreased the parenchymal venous vasculature. So all of these are individual little entities or little points of light that we try to focus together on the problem we have and trying to understand what's going on with CCSVI and its relation to primary neurodegenerative diseases. Where does this occur? Again, we've talked about lesion sites and lesion etiologies in some of the debates to date. I think you're well familiar knowing that there's a multiplicity of locations where we can have venous obstruction, and multifactorial, the exact causes of this obstruction. I think overall the vast majority, as we talked about in the debates earlier, are due to valves, and this again work that was presented at ECTRIMS by Dr. Fox at the Cleveland Clinic, showing that, surprising to these neurologists, there were far more numbers of circumferential membranous structures, longitudinal-oriented membranous structures, etc. In other words, hemodynamically significant venous abnormalities in MS patients as opposed to normal controls. And you may be aware of this study, but this, I think, coming from a renowned neurology group at the Cleveland Clinic, is very powerful in terms of convincing some of our neurologists that maybe they should pay a little more attention to CCSVI, and again, wanting to investigate the pathogenesis of CCSVI and its relation to MS. We've been looking at the actual collagen subtypes in CCSVI veins and have found that indeed they sort of parallel what we see in varicose veins in the legs in terms of the ratio between subtype 1 and subtype 3 of collagen. This in varicose veins is well described. We're starting to see the same thing in veins above the valves in MS patients. So what is the data from MR venography? This, as you may be familiar with, is looking at comparing a meta-analysis, which that means it takes all the stuff from the literature and compares the data between those in favor of CCSVI and MS and those saying there's a less likelihood of CCSVI and MS. And again, from the Canadian Medical Association Journal published, it says that most of the data to date does in fact support increased likelihood of CCSVI in MS patients compared to healthy controls or those patients who have other neurological diseases. The one problem is there's a severe difference between the results of ultrasound. And here's Dr. Fox again. I think I'll just close up with this.
One of the confusing aspects of CCSVI in the last couple of years is the very, very different results that have come from different studies. Some showing that there was an association with MS, and others showing that there was not an association with MS. The 100 to 0% has to suggest that the way the test is being done is different. The way one group is doing it and getting 100% is vastly different from the way another group is doing it and getting 0%. We need to better standardize how the ultrasound assessment is done across all sites.
So I think what I'd like to close with is this current snapshot. I think there's general acknowledgement that just looking at anatomy alone is not sufficient. It's inadequate indicators of venous disease. It doesn't really tell us what we want to know, which is physiology. Certainly MRV and CTV, you've heard some of the limitations of those technologies in terms of false positivity, false negative. Ultrasound is certainly better at identifying interluminal lesions, but is a very operator-intense, time-intense, hard to blind patients knowing whether they have MS or not, and it depends on multiple criteria. And catheter venography, the problem is it's invasive, and experience suggests that it is also a tarnished gold standard for CCSVI because it really doesn't show us the valves. So now we have to move forward to the next phase, which I think will be from 2012 on, and that's recognition that's critical we understand the physiological relevance of these anatomical abnormalities. So the luminal narrowings, the obstruction in the jugular and nasicus veins, what does it really mean and how do we know it's significant? And there are many ways we can do that, and that's the next challenge, and that's, I think, what we'll be talking about in the years to come. Thanks very much.
Okay, thank you, Dr. Dake, for getting us started off this afternoon. Dr. Hubbard, do you want to come on to the podium, or do you want to wait? It doesn't make any difference right now. Okay, Jack Burks is our next speaker, and if you look in the program, he is medical director for the Multiple Sclerosis Association of America. And we are, I am apologizing here, Dr. Stanley Krolchek was on the program, and he had a personal emergency that was not able to be here with us today. So I want to say thank you to Dr. Hubbard and to Jack Burks for being flexible and for filling in here. So, okay. Jack?
Well, it's a pleasure to be here, and I always enjoy going to patient meetings because I learn a lot as well. Well, I'm a neurologist, and my goal in being here and working with this organization in the CCSVI Alliance is to bring together scientists from various fields to sit down in the same room and say, what do you know? What do you know? What do you don't know? And I'm going to talk about the format for doing that. And then we can get together and say, well, I think we could do a study that says, I might say, I think we should do a study that says we should do this. And I think if we do that, we can really prove the point. Dr. Hubbard will say, that's crazy. I would never believe that. No, we should do it this way. And another doctor will say, no, you're both wrong. We do it this way. And we come together, though, in the same room. So instead of throwing darts at each other from passing cars, we actually sit down in a room and say, okay, how are we going to compromise an idea that if Dr. Hubbard has an idea and I say, okay, I'm with you. Then Dr. Hubbard says, okay, if I prove my point, will you sign the paper with me and present this data with me, and so we can go to the world united? Because we are not united. Neurologists are not united with the CCSVI people, except for a very few people in neurology. And we need to come together, I think, for the best result. And actually, the concept is pretty good, what's happened so far. There's a theory that veins have something to do with MS, and maybe if we did something about it, we could help people. So that's the first step. The second step is you do a pilot study. And that pilot study is you take a few patients, you make some observations on them, and you say, what do you learn from that? Well, we learned this, that, and the other thing, and then you develop maybe another pilot study or maybe another pilot study, and then you actually come together and say, okay, this is what we know from the pilot studies, which are not scientifically valid, particularly, but they're interesting and they say important things, and then we come together and say, okay, what can we agree upon are the critical elements for the next study? And I'm going to talk about that, but my goal is to try to get people to work together instead of, I go to the neurology meetings. I went to the ECTRIMS meeting in Amsterdam that you showed Bob Fox. There was a seminar that I have never seen such a ripping of a procedure as the neurologist did with CCSVI. It was awful, this. And Dr. Zvadanoff asked a question. Dr. Zvadanoff asked a very reasonable question and said, that data's not important. We won't address that. That's what he was told. So that shows you how the animosity is growing among professionals. And unless we get the professionals together, we're going to have trouble. And I'd like to see the patients have a role in this as well. And today, I'm here to talk about what I think your role will be as well. So let me go to the first, with that introduction. Is this? Okay. Okay, what do my colleagues say about CCSVI? Well, they say, well, they see patients. They come through their office occasionally. Some are better. Some say, doctor, it didn't work. I got no help whatsoever. Some will come in, and then will come and say, maybe it helped a little bit. I don't see much, but I think I feel a little bit better, doctor. And some will come in and say, I feel much better. And I do the exam, and actually they do seem to be performing well. I don't know for how long that will be, and I don't know if that's the placebo effect, and I'll talk about the placebo effect in a minute. So I'm not sure what to make of that. But I do see reports, not in the scientific literature where it should be, but in the newspapers, that it kills people. Well, we all have deaths, and no matter what we're doing in life, we walk across the street, we take a risk. So where does that fit? People die with MS, people die without MS, people die with CCSVI procedures. So where is all that, and where does that fit? But if we don't know the data, then we tend to catastrophize. We say, oh gosh, this must be terrible. This patient did this and this patient did that, because I read about it in the weekly newsstand, not science. And then we say, well, most patients aren't being evaluated. Sharon says 20, 25,000, who knows, 30,000 patients had this procedure. There's been data on 120 presented. That's what one of the speakers said this morning. Well, how can you expect neurologists to say, oh yeah, man, this is great stuff? They're not going to do that. That's not our style. That's not what we do. And so what we say, okay, I don't know what to do. I'm confused. I'm just going to wait until they give me more science. These are the guys who are doing it. Give me more science. I'm not going to have something to evaluate. And I believe, and that's most neurologists think, this is going to go away. It's going to go away like bee sting and snake venom and everything else. And if I just leave it alone, and I try not to get in the middle, I don't want to make my patients hostile. If I just leave it alone, I'll be okay. But the one thing I know, we don't have the data to support this, and first I'm going to do no harm. And I don't know what the harm is. But can you see how neurologists might feel that way, sort of possessive about their patients? And we don't want to hurt anybody, and we don't really know the problems. We've heard today that it's an absolutely safe procedure, and there'll be a newspaper article tomorrow that says it killed somebody. So what are we supposed to know? We're neurologists. We're not doing these procedures. And we have an experience with new treatments. And those experiences, there's been over 100 breakthroughs of MS in the 40 or 50 years that I've been doing this, forever. And not one of them has survived scientifically. Not one that came out of this sort of thing. So therefore, we tend to be, let's look for data, not theory, and not excitement. We want data. And snake venom, most of you are around long enough that, remember when the snake venom cured MS and bee stings, and there was actually a treatment giving patients malaria 40 or 50 years ago. They drive their temperature to 104 degrees to kill all those viruses that were causing MS. Surgery on brain arteries. So we've actually worked with brain stuff. There was a guy, Hurwitz, in California who was operating for $100,000, operating on people's vertebral arteries going to the brain about 30 years ago. So we have that experience. I put cow's milk in there too, so make sure you drink your cow's milk. But anyway, that's been our experience. And so we're skeptical until we see data. And 120 patients out of 20 or 30,000 is not data. I'm going to give you an example. You think we're just beating up on the interventionalists and the diagnosticians? No, we beat up on each other too as neurologists. There was a paper presented at the American Academy of Neurology, which is sort of the primo neurologic convention in the world, that said that there was a 50% reduction in gadolinium-enhanced lesions in MS patients in just 6 months by giving a patient statin. Wow. Pretty impressive. Pretty impressive. That's objective data. That's not somebody feels better. This is the MRI, the holy grail. 50% reduction. Wow, that's just great. What did neurologists do with that? They analyzed the data and said there was no controls. And they only took patients in this study that had lots of lesions. And we know that if you take somebody with lots of lesions, do nothing to them, the lesions, you go up and down, they'll get less. So let's do the studies. So the next study came out and said the statins actually interfered with interferon treatment, the disease-modifying therapy that has been shown to work. The next couple of papers said, no, that's not true. But we did all this quietly. You didn't hear about this in the paper. There weren't blogs about this and patients demanding statins, although some people got statins. They felt they should get it. And then there was finally a really good study says that statins do not work in MS. And now statins is a dead issue for MS right now. That's how neurologists have done this. And in many ways, there's some similarities here because we're all excited when we see the preliminary data of CCSVI because there's some things in there that are really interesting and what's really going on. And it's hard to believe there's something going on in those veins, even from the neurologist who are saying, well, you guys have to go in a corner and tell me what's the best test and how reproducible is it and how simple is it to do. Well, you just had a conference here this morning that got no agreement on that. And Dr. Scalfani, he's made the statement. Is he in the room? Shall they make it again? I don't think any of them are very good. That's what I heard him say. I don't know what you heard him say. But anyway, so that's how neurologists get into this business. And so don't take it personally when we actually criticize science or pilot studies that we judge as science. And the problem is, the first step was fine. We got the theory. The second step, we got the preliminary data. The preliminary data for Dr. Zamboni, he's not here, was actually pretty darn good. Because what you do in a preliminary data pilot study is you take a few patients and you see what happens to them. And then you say, what do I do next? That's actually pretty good. But the neurologist decided that they would put the criteria on that pilot study that we would use for a phase 3, a late study to go to the FDA for approval, which is you have to have all the things I'm going to talk about in a minute. And of course it didn't have that. But the key is it should have stimulated the next round of more rigorous research. And we're waiting for that. It's starting. You'll hear a lot about it. There's a lot of things going on this week that you're going to hear about. That's very exciting that we're trying to get the results. And Dr. Dake is also planning one of the studies that I think will be very helpful in trying to put this into perspective. But okay, here are the questions that we ask. Does CCSVI exist? Most neurologists don't think it exists. In spite of all the data you're going to hear, neurologists say none of it is. There was a guy at ECTRIMS, a very renowned doctor, scientist, who says, we have looked at this conclusively, I'm very experienced in this, it does not exist. That was the paper. So what are the neurologists sitting in the room supposed to think? Do I believe somebody I've never heard of, or does this guy here is coming up to talk to me? So we just don't know yet. And we need to get our act together when we talk about diagnosis so that we can agree on a diagnosis. And one of the leaders of neurology said recently, why fund research to get rid of flying saucers? Because flying saucers don't exist, CCSVI doesn't exist. So we've got a ways to go. And the way to get over that is to sit down and talk with each other in a scientific forum. Okay, so what's the role of CCSVI in MS? And this is what I'd like to talk about. And we're getting this data right now. What % of normal people have CCSVI? What % of different kinds of MS have it? Does CCSVI come first? In other words, you get CCSVI and then get MS? Or do you get MS, the brain shrinks, and you get CCSVI? We don't really know that. Could they be two separate entities? Does that make sense? These are the things that we really need to address. And does the fact that we find CCSVI in an MS patient or a Parkinson patient or somebody with irritable bowel syndrome or whatever, if you treat it, does that really help them? We still don't have the data to say that. Okay. We don't know what kind of procedures. So, okay, say you have CCSVI and we said, okay, let's study it. We have to decide, is it going to be balloons or stents or something else? And how do we deal with the placebo effect? And the neurologists would say the placebo effect is about, if you give somebody a placebo, 1/3 will get significantly better, 1/3 will get a little bit better, and 1/3 won't get better at all. And that's just from the placebo. The statin paper, 50% of the patients, there was a 50% reduction in gadolinium-enhanced lesions. That was the natural history of the disease when you have a lot of gadolinium-enhanced lesions to begin with. So that would be considered a placebo response because it turns out that was not accurate. So it isn't. So we pick on each other too. We don't understand pseudo-exacerbation. You know what a pseudo-exacerbation is? That's one of the things that neurologists know quite well. People who get a urinary tract infection, they'll get symptoms. Their old symptoms of MS will come up. If they have a good day or a bad day, sometimes people will have great mornings and bad afternoons. All this stuff has to be considered. And you can't just say, well, they felt better. There has to be something more precise. And is it a treatment for the disease? Is it a disease-modifying therapy? Is it an interferon? Is it Copaxone? Is it Gilenya? The things that have been shown to be approved by the FDA? Or is it a symptom management? Or is it something that helps quality of life? Now, I don't want to minimize that, because I think if this were a symptom management, if this were two separate diseases and we could help the symptoms of patients, I'm all for that. And if we could help their quality of life, I'm all for that. And the next, are they safe? So the opportunities. More neurologists are getting involved. There are a number of neurologists at this meeting coming up. There is government funding. There's MS Society funding. Dr. Hubbard can talk about his registry. That's a really important step. We're getting the diagnostic testing is getting better defined. Trials are starting, and we're moving along. It's just that I'm trying to figure out how we can move along more quickly and more scientifically. And so who would be involved in this collaborative effort? Look at all these people that need to be involved. I mean, there are a lot of people here. I can't quite get this working, but I'm not going to go through the groups. But there's a lot of people who are involved. We talked about multidisciplinary. We talked about in diagnosis, multidisciplinary in treatments, and evaluating the outcomes of treatments. All these people need to be involved. And I'm going to put down MS patient groups as an important part of this, and the advocacy groups as well. So what's the format? I'm going to recommend, and I did this before when the Consortium of MS Centers was just beginning. I co-chaired a conference in Denver, Colorado, where my MS center was, where we brought people together from all different disciplines interested in MS. We said, what do we know? What do we know about MS treatment in rehabilitation, in drugs, and psychology, and cognitive issues? And we got together and we planned what should be done. And we wrote a document, and that document's published. So the first question you ask at this meeting is, what do we really know versus what we think we know, but we really don't have the proof for that? So we sit down and we say, well, what's real proof? Where's the science here? And the second is what do we think? And the third is, what do we all agree that we don't know? We don't know what's going on here. And then we develop a strategy to answer those gaps. We prioritize them. We say, now the most important issues for us to look at in studies is this, this, and this. But it's based on science. It's based on evidence-based medicine. And then we say, how can everybody in the room contribute? What are you going to do? What are you going to do? What are you going to do? And how are we going to work together? So I know what you're doing, and you know what I'm doing. If I criticize you, I'll criticize you to your face. I won't do it in public. And then how are we going to fund it? This is not a small issue. But if you just think about, you said 20,000 people, let's say 20,000 people, and it costs $10,000 for everything, for the transportation, for the surgery, whatever. Maybe it's 20,000. Some of my patients say it's 20,000. Well, that's about $400 million. So there's a lot of money in the pot right now. It's a lot of people getting a lot of very expensive treatments. So it's worth it financially as well. Somebody ought to be funding this. And the goal here is a collaborative, if we have a collaborative effort to gain knowledge, we're going to answer many of the questions. And until then, CCSVI remains experimental and unproven. And it should only be done in a research setting. In other words, if somebody's not going to follow you, if somebody's not going to look at your results in a series or with a control group, I think it should not be done commercially. And I think people should not spend money on unproven things until we know. And we should really put the emphasis not on opening up CCSVI centers at dialysis center, which I heard about earlier this morning. The dialysis center is now going to start doing CCSVI when we know how hard it is to diagnose it today. One thing we learned is really hard to diagnose. It has to be done under a supervised investigational setting. And so the good news, so what can we learn? What are the things that I think would be helpful? What are the best diagnostic tests? Which are the best treatments? For what patients? Who's going to benefit? Can we define who's not going to benefit so people will actually know what their choices are, whether they're going to be beneficial or not? And what benefits can you expect? Can you expect to get out of your wheelchair and run the 100-yard dash? Or can we expect you to be able to continue working? What can you expect from this? And how long do the benefits last? We've talked a little bit about restenosis and retreatments and things like that. We need to have that better defined. and when to retreat, what to retreat with, and what are the dangers. Is this a complementary therapy to disease-modifying therapies, or is it a standalone therapy? Can this handle whatever we need to handle alone? And another important issue, and it was touched on by Sharon, is to identify the best doctors and best facilities. This is not for amateurs. This is not for somebody who says, oh, what am I going to do this week? Oh, I think I'll start a CCSVI clinic. I don't think so. You need the best neurologists. You need the best surgeons. You need the best diagnosticians. Make sure you go to the right places. And what outcomes need to be measured? Well, I think that we don't know yet. Is this a disease-modifying therapy, or is this a symptomatic quality of life therapy? So we may have to ask both questions. And it may be, for one group of patients, it's a disease-modifying therapy. Another group, it may be a symptom management therapy, and for another group, it's nothing. It's not going to help these people. We should have to define what that is. And so look at all of if it's a disease-modifying therapy, the standard is relapses, disability, MRI. That's what we expect as a neurologist. But in symptomatic management, we have all these things down here. We say, well, we can't measure those because we'll just ask people how they feel. That's not true. These are measurable outcomes. If we sat down together in a group with experts in these areas, they could tell us how to measure it. That is believable. So this idea says, well, we'll just ask if they feel better in a month. No, it's not going to fly. And also we have to look at other outcomes like quality of life. I mean, if we can improve quality of life, that's really important. And caregiver. Work with caregivers, and somebody mentioned that, and one of the things, they work with the caregivers. We need to look at what happens when to marriages, et cetera, partnerships. What happens to their work environment? Are we allowing people to go back to work or stay working? Those are all very important issues. And what about the medical resources and also recreational activities? And so I think that I want to end with what I think you can do as patients. I think you need to figure out how to work with your doctors. Neurologists are not easy. I admit we're not easy. But we're analytical, and we know a lot about the brain, and we can be helpful if we get involved in this process. So figure out how to do that. And I was asking Sharon about it, and she said, well, the CCSVI Alliance has a website that can really talk about that sort of stuff. So I'm going to encourage you to go to the CCSVI Alliance website, and maybe Sharon can talk about that later. I think your role would be to help the medical team. And try to bring them together. And define what your role is in the decision-making process. And my whole concept is this should be a shared management decision-making process. And learn the best questions to ask and how to ask them. A lot of people have good questions. They don't know how to ask it because they don't know how to work with neurologists because we sort of think strangely maybe. But learn how to frame your questions so you'll get the most appropriate answers. And participate in clinical trials. I think that could be very important, and also volunteer to help efforts in this field. So thank you very much.
Okay. Thank you, Dr. Burks. Dr. Hubbard, do you want to go ahead and take a minute and talk about your foundation and the registry? Before.
Talk about MS.
Okay. That's fine.
I want to talk about his registry because I think it's a great
I don't. Are those on? So right now we're going to have two neurologists have a conversation here.
So when my son was diagnosed with MS, 2009, I went back to the literature. I was at Einstein, where Aaron Miller and Leib Scheinberg were, but I hadn't paid attention. And it was clear to me almost immediately that the autoimmune model had not been proven. The drugs were in the 35 to 38% range of effectiveness. No one has been able to show that the immune system is attacking myelin. In fact, the best papers were by Prineus and Barnett, who showed that the oligodendrocytes were dying first. The immune system was coming in to clean up the mess. That plus that old stuff about the fact they're perivenular, that macrophages are not part of the T cell system, that they're part of the innate system. It was enough for me to go to that meeting in Hamilton that started it all, where I met Dake and Zamboni and Heikki and everybody else. And to me, the theory made enough sense that I took my MRI facility and converted it into being able to follow the Heikki protocol. And I arranged to get my son treated. I had to sort of sneak an IR into doing it because everyone was against it. So at this point, it really isn't a matter of whether Doppler works or MRV works. It's what is it going to take to move this thing forward. And I want to ask you about that from a neurologist's point of view. It seems like it's going to take two things. It's going to take a double-blind, placebo-controlled trial. Even though I hate the idea, it's going to take a sham venoplasty. And it's probably not going to just be one trial. So Saskatchewan is paying $2.2 million to Gary Siskin to do 86 cases. It's probably not going to be quite enough. There's going to have to be one or two more sham-controlled trials. I'm actually a little bit nervous that we're not quite ready to do it. We're going to have to go ahead and do it, but we're really not quite ready for the debate that we heard this morning. Is it the valve only? Are there other locations that matter? Are we just having to assume that trying to increase flow at the bottom of the jugulars is really what this is doing? Is it possible it's having some other effect? So I think that's part of it. For me, as a neurologist, the real action is what are we thinking it's doing? What is happening in the brain? We don't really care about the jugulars, right? We care about the brain. I'm sort of putting my money on that those 5 studies that there is hypoperfusion that is not explained by atrophy. So I think perfusion is going to be the way we know whether the brain is in fact being properly drained. Only if we show increased perfusion after a venoplasty procedure are we going to know. If we simply balloon the bottom of the jugular, we don't really know whether we did it adequately or effectively. We don't even know whether it was the right vessel to treat. But if we can look at perfusion in the brain, we'll know. And neurologists listen to that. They listen to MRI data. Perfusion may not be the entire answer. I like to put it all together by saying that the reason that Prineus and Barnett found oligodendrocytes dying before the immune system got involved is that the oligodendrocytes are living in a stagnant brain, that poor perfusion is killing the oligodendrocytes. That would be a mechanism that might put it together and might interest neurologists. So where I think we have to go is we have to just go ahead and just bite the bullet and do a couple of double-blind placebo-controlled trials, and then we have to have some studies done on the basic science of perfusion that will get other groups interested and that will move us toward understanding as to why the venous system makes a difference in these diseases. And then finally, I'm a dad, right? So I'm not just a neurologist. So what am I supposed to do, right? I'm not going to wait 20 years for you guys to be happy with the results. I got to make my own decision. And so I made the decision that the venoplasty was safe enough, that it made enough sense to me that damn everybody else, I was going to recommend it to my son. And that sort of means that I'm not really... So in a way, I'm really not an objective scientist, right? I'm an advocate, and that sort of puts me in a different role.
Well, I'm also an advocate because I have a family member, a close family member with MS, and I have my best friends with MS, and I've had very best friends dying of MS as well, and so I feel like I'm very much on a patient advocate side of this. My family member who has MS has not had the testing and has not had the procedure. My feeling is that we really need to know more before I'd be comfortable recommending that to her until we really know what's going on. Because I was around when everybody got snake venom and everybody got bee stings and everybody got all the other sort of things. And it's disappointing because I think people come here to say, these guys are going to tell me to go do it. I'm going to say, I'm telling the doctors and the scientists to do their work first before they commercialize this for patients. And that's the way I feel about it.
What do you think about the autoimmune theory? Do you think it's viable?
Yeah, I think there is an immunologic component. I think the current disease-modifying therapies do work. And don't confuse a 35% reduction in something as being a placebo effect, because those patients were actually compared against placebo. So they got one leg up. Now, this was 35% better than placebo. And now the newer medications are actually even doing better than that. And there was a study that that hasn't gotten much publicity that says that people who were on treatment for 5 years versus the people on placebo who then got other treatments at 21 years, that there was better longevity, less risk of death than the people who were treated just for the first 5 years, for the entire 21 years versus the people who delayed 5 years of treatment. That's scary to me, and I think we have to recognize that and this was data done by arguably the best epidemiologists in the world who were not part of the pharmaceutical hierarchy, let me assure you. So I worry about that, and I just think we need controls, and we need to be blinded, and the patients have to be randomized. I mean, I've seen studies that have actually been published in, I think, not very good scientific journals that says if you take a group of patients with treatment A and a group of patients with treatment B, there's no difference. But the criteria for getting in it was the doctor's decision, and we know that we only gave treatment A to people who had mild disease, and we gave treatment B to only people who had severe disease. So you can't compare those. You have to have a randomization. Some? Yeah, I do. I don't know what the effects of CCSVI are. I do know what the effects of Tisabri are, but we have 120 patients. We have 120 patients. I think the risk of Tisabri is greater. Okay? From what I know. Because right now there have been no deaths reported in CCSVI, and there have been a number of deaths reported with Tisabri, and I see CCSVI is in the realm of treatments that have no proven efficacy and no safety data that is comfortable. So therefore, we're saying I think the better question is, would I recommend snake venom or bee stings as well? We don't know. We don't know about those. Okay.
Tell me about what you suggest to a person who takes Tisabri or interferon or Paxil with respect to that they are
Here, you deal with it.
I'm sorry. What was your question? I know. I understand. And I don't blame you. I wish I could say that this would work. Okay.
because you're not categorizing these things correctly. And what you've done is you've lumped into things that you will assume as you're framing the argument that it is snake oil and all of this stuff. You've assumed that without proof.
I agree with him, actually. There's not been a double-blind placebo-controlled trial.
That's not the only way you
It's where it has to begin. It has to begin there. So AstraZeneca,
Excuse-
let's get to it. Why isn't, you got $1 zillion. Why aren't you doing that study?
Well,
Okay.
well, I agree with you. I really think you're absolutely right. We have to pick our patients. We have to know. And then one of my slides says who will benefit, who will not. I mean, one of the major research areas in MS now is something called biomarkers. We're trying to say, can I look at a biomarker before I treat a patient and say, I'll give the patient drug A, drug B, drug C. And what Dr. Hubbard said, and I think it's really important, is we must promote the science of this. We don't have enough science of this. And so therefore, yeah, and evidence-based medicine has very specific rules. And it starts with science, as he said. And so I couldn't agree with you more. We need more science to understand this. But we also need more patients, which you said as well. You can't make conclusions on anything. And so do you want to give patients, you want to recommend patients where there is no conclusive evidence that it works? I don't feel comfortable doing that. I have drugs that do have conclusive evidence that works and other drugs that are getting better. And if somebody said, should I take drug X or treatment Y, I would say, well, we have data that's gone through the rigors of evidence-based medicine that says it works. We don't have that for this other thing. And so if you want my recommendations, I would go with the evidence-based medicine. And here are the toxicities. I know the toxicities of Tisabri. I don't know the toxicities of CCSVI because there are no published data that talks about the deaths of patients with CCSVI that I'm aware of.
Yeah, Dr. Burks, excuse me. We're running a little short of time here, and so to keep things moving along, we'll get back to, we're going to have a long period of time at the end of the day for question and answers, and Mike Dake will be moderating that session. So be sure and keep your questions towards the end of that, and then we'll make sure that we get people out that want to leave or whatever, okay?